Hi everyone, I'm Emma Eggleston, Dean of the WVU School of Medicine, Eastern Division. Welcome to tonight's Mini Med School. The topic of tonight's program is lung cancer, from early detection to cure. Lung cancer is the leading cause of cancer death here in West Virginia and in the nation, and it represents more cancer deaths than colon cancer, breast cancer, and cervical cancer combined. We're very fortunate to have with us tonight Dr. Ghulam Abbas, Chief of the Division of Thoracic Surgery at the WVU Heart and Vascular Institute. Dr. Abbas is a national expert in lung cancer diagnosis and treatment. Thank you, Dr. Abbas.
Hi, morning. I'm Ghulam Abbas. I'm the Professor and Chief of Thoracic Surgery for WVU Health System. I'll be talking today on lung cancer. I wanted to give you a brief update on the lung cancer, smoking, and association of smoking with lung cancer. So lung cancer is a lethal disease. Almost 1.6 million people die every year worldwide, and there's almost 170,000 people dying of lung cancer in the United States. 22% of all cancer-related deaths occur because of tobacco abuse. And this is a product, if used as the manufacturer's guideline, it kills. So if you, for example, go to any department stores, go to Target and use Clorox says we have the best bleach. Use it as the manufacturer's guideline. It gives you some help. It may not be the best cleaning bleach, but it cleans. Cigarette is the only product available on the shelf. I challenge you. If you use it at manufacturer guideline, which says take it out of the packet, lit it, and put them in your lips and inhale. And if you follow the manufacturer guideline, the science tells us everybody dies. Some people may die in 40 years, the other people may die in 200 years. So every human body is different. So this is the only product available in the market which, if used as the manufacturer guidelines, it kills and harms. And it causes non-cancerous condition and cancerous condition. And from top to bottom, it starts from the head and neck cancer, lung cancer, esophageal cancer, bladder cancer, and all different kind of cancer and non-cancerous condition it can cause. It harms the person who smokes and uses it, and it harms the loved one too, because they get exposure to the secondary smoking. It started with Native American used it for ceremonial purposes, and then Columbus brought it to Europe. Philip Morris actually used to sell on the streets of London. He will wrap it in a paper, the tobacco, and people will use it as a smoking. And James Duke brought it to the United States and the Carolinas in 1800. In UK, the Royal College of Physicians concluded that in 1962 that it can cause lung cancer, and the US Surgeon General in 1964 echoed that it can cause lung cancer and it causes harms. So it's still 60 years later, it's still available in market, and anybody can buy it if you have money in your pocket. When it's used, it produces all these well-known toxins which are included in the cigarette, and these all toxins are known to cause cancer. Now, once you quit the smoking, the side effects of the smoking slowly disappears, like the blood pressure and the heart rate drops to normal in 20 minutes. In 2 weeks, the circulation and lung function start improving, and 10-year risk of dying from lung cancer decreases to half, and risk of heart disease decreases to the level of a non-smoker in 15 years. So it takes a long time once you quit smoking to get rid of the risk associated with it. And it's an addiction. People try to quit, but it's hard to quit. And so in last 10 years, we have 2 good randomized controlled trials showing that lung cancer screening leads to early detection of the lung cancer and save lives. So that's among all the modalities we have, surgery, chemotherapy, radiation therapy, lung cancer screening is the single modality which has the biggest impact on the lung cancer survival. It reduces the mortality in these in lung cancer patients. Initially, the eligibility criteria was 55 to 80, is down to 50 now. 15 packet history of smoking, and it can be done in any medical center. The National Lung Cancer Screening Trial was the first trial. It started in, published in New England Journal of Medicine, showing that there was a decrease in mortality related to lung cancer and non-lung cancer related conditions in this high-risk population. So what they did in a multi-center trial, age 55 to 74, 30 packet of history of smoking, and they did annual low-dose CT scan in these patients as compared to chest X-ray. And they looked at the data, and there was a decrease in mortality from in the CT arm by 20%. And in the non-related lung cancer patient, like 7% of patients was found to have other conditions which could have been lethal, like aortic aneurysm, which were detected. Then the next trial was, I'm going to skip these couple of slides. This is a European trial which also shows the same findings as compared to the National Lung Screening Trial, which was done in the United States. And in this group, usually women had a more benefit than male, and almost 26% reduction, 26% reduction in lung cancer related death. So that's the single modality which has such a huge impact on the lung cancer survival. The lung cancer screening program is not easy to implement. That's why it's not readily available nowadays. I mean, in the last 3 years we have seen that it's become more commonly available because it takes a lot of effort, and we need a dedicated nursing staff, a coordinator. You need special equipment, accreditation from the American College of Radiology, and all these different pillars are needed for a successful lung cancer screening program. So how it is done is a low-dose CT scan of minimum radiation. You need a board-certified radiologist. You need accreditation from American College of Radiology or another agency, and you need a MD or APP running the program. And then lung cancer screening, and then you need a navigator to follow up on these patients who have a positive results. I'm going to skip all these slides, but these are just few examples that and the this lesion, which is showing on the low-dose CT scan, it can be benign or malignant. So depending on the severity of these lesions, they give it a RAD 1, 2, 3, 4, and RAD 4 is the worst when it's suspicious for lung cancer. So this nodule, and if you look at this is, unless proven otherwise, is a lung cancer. So if you have a nodule like this in a patient who have a history of smoking, and a PET scan shows this nodule to be positive, you probably don't need a biopsy, and unless proven otherwise, it's lung cancer and need to be removed. And obviously a biopsy can be done before removing it. So once the lung nodule is detected, the next step is, if it's suspicious, you can proceed with surgically removing it. Or the other option would be to do a biopsy. So if it's suspicious, no, repeat a CT scan in 3 to 12 months. If it's suspicious, then you get a PET scan. If there's no distant metastases, then you proceed with a biopsy, either with a robotic endobronchial biopsy or a bronchoscopy biopsy. And if it's the mediastinal lymph node are enlarged, then we need a EBUS, we call it endobronchial ultrasound, which will give a biopsy of the lymph node, which will give a diagnosis and a staging. And if there's no mediastinal lymph node involvement, there's no spread anywhere else, you proceed with a robotic resection of minimally invasive resection of these lung nodules. And just few examples. So this lesion looks as though it's small. It's, unless proven otherwise, is a lung cancer, and it should be resected with minimally invasive techniques. This one, unless proven otherwise, is lung cancer. This will be a segmentectomy where you remove a small portion of the lung. This will require a lobectomy where you remove most of the lung, most of the lobe, half of the lung. And these are advanced stage lung cancer where these are unresectable and probably will need chemotherapy and radiation therapy. Surgery will not play a role. just a prime example, this is a patient at a lung cancer screening which detected that this shows a early stage lung cancer, and a patient like this with a history of tobacco abuse, this nodule is almost always a lung cancer and need to be removed. So it's a minimally invasive cancer. A robotic segmentectomy will remove this with curative intention. This is the same nodule in a follow-up because the patient selected to proceed with follow-up and showing more dense as compared to the previous nodule and was resected. Now the next step, once you have a nodule like that, is you have to get a PET scan to make sure that it's not spread to anywhere in body. The PET scan is a special scan where we take a radioactive molecule and connect it to a glucose molecule and inject it into the vein. And the tumor cells or infection cells are rapidly growing. They take more glucose. There will be more intense uptake. So that's this lesion showing a liver metastases. This is the lung lesion with the increased uptake in the lung. It gives you an idea of a clinical, help you with clinical staging of the lung cancer. Biopsy is another option. This is a CT guided biopsy where a needle is placed into the nodule under CT scan to get a tissue for diagnosis. Now the navigation bronchoscopy is an old technique, and now we have the robotic navigation bronchoscopy. We have the intuitive ion system where the CT scan is loaded on the computer, and bronchoscope is passed through the windpipe and get to the nodule and biopsies the nodule to obtain tissue for diagnosis. EBUS, the endobronchial ultrasound, is very important to stage the lung cancer. If the lung cancer, the first thing you do is a PET scan, which will tell you if there is distant metastases, that is a spread anywhere else in the body. If that's the case, that's a stage 4 lung cancer, is advanced stage. If the second thing is, you always want to make sure there's no mediastinal lymph node involvement, because if there's a mediastinal lymph node involvement, that's a stage 3 lung cancer, and patient will need chemotherapy and radiation therapy before surgical resection. So endobronchial ultrasound is a fancy bronchoscope which is placed in the windpipe. The ultrasound will show you the lymph nodes outside the windpipe, and you biopsy it with the needle. And if as I said, if there's no metastases, distant metastases, and there's no lymph node involvement, then the best way to handle it is to do a minimally invasive resection. And at WVU, we prefer to use the robotic platform, and we perform robotic segmentectomy. Now the segmentectomy is a lung preserving surgery. Even patients who have COPD on 2 liter or 3 liter of oxygen, we most of the time are able to do a segmentectomy and resect that small portion of the lung where the small cancer is. Most of the cancer we're detecting with lung cancer screening program are early stage, so they qualify for a segmentectomy or the lung preserving surgery. For example, if you look at the lung anatomy, the upper lobe of the lung has 3 segments. So if you have a small tiny nodule right here, you don't need to remove the whole lobe. You can remove just a segment. Same thing with the lower lobe, both on the right and the left lobe. These are called lung preserving surgery, and our center is one of the which has one of the largest experience in the world in robotic segmentectomy. And the data initially came from Japan, where they showed us segmental resection and lobectomy at the same result for tumor less than 2 centimeter in size. And this is an old slide. We have close to 200 segmentectomies. With the robot, our median length of stay is 2 days only. All right, I'm just going to give you just a quick example of the robotic segmentectomy program here. You see this is small nodule in the lung in the posterior segment. That's right here is an early stage. This was found in the lung cancer screening. So removing the whole lobe will be unnecessary in a condition like this. This is the robotic view. That's the zygous vein. That's the back of the chest. This is the lung being retracted to the front. This is the lymph node being removed. That's the windpipe. That's the bronchus, windpipe of the lung. That's the vena cava. That's the phrenic nerve. That's the heart beating right here. And we're trying to remove a small segment. Now, the segmentectomies are usually more challenging than a lobectomy because you have to dissect inside the lung parenchyma, as you see, and have to find the artery, vein, and the bronchus and do a dissection in the lung. So that's why the robotic platform provides superior approach, because the dissection is very meticulous. It gives you a very opportunity to do a very fine dissection inside the lung parenchyma and find these blood vessels and the windpipe and cut it through and save the remaining bronchus and the artery for the upper lobe. So this is we're using the robotic stapler to remove the artery or to cut the artery and vein of the segment, and that's the small windpipe, which is a windpipe supplying only the posterior segment of the upper lobe. You can fast forward it, Joe. So, and then you go and remove that part of the lung where you can the nodule is included. We can finish it. Go to the next slide, please. Or I can go to. So adjuvant therapy, when you have a stage 1 lung cancer, which is just confined to the lung, you don't have to have any further treatment. So 2/3 of the lung cancer found in lung cancer screening program are a stage 1 lung cancer. So those patients, you can do a robotic segmentectomy, so you're preserving the most of the lung. They have minimum effect on their breathing after lung surgery, and they usually stay in hospital for 2 days and go home. But if it's more than stage 1, when any of the lymph node is positive, then it's stage 2, or the lymph node around the windpipe are positive, that is stage 3, they're locally advanced disease, then you need chemotherapy or chemo and radiation after surgery. So this, for stage 2, you need chemotherapy. Stage 3, if it was not detected preoperatively, you will need chemo and radiation after the surgery. These are multiple trials. I wouldn't bore you on these. The message here would be, in looking at these slides, as there's so much advancement in the treatment of the lung cancer. So a simple lung cancer usually used to be divided into a small cell and non-small cell lung cancer. Now the non-small is the squamous cell or adenocarcinoma, and then we divide the adenocarcinoma into papillary, well-differentiated adenocarcinoma, papillary, SNR, micropapillary, and solid. And these are further subdivided into different subcategories depending on the lymphovascular invasion, depending on the spread through ear space. So the lung cancer treatment and classification has significantly changed and has basically exploded. And with the immunotherapy being available as a preoperative treatment and postoperative treatment, the survival and outcome of lung cancer has significantly improved. And among the surgical platform, I think the robot has made a significant difference in the approach of these lung cancer surgery. So just wanted to give you an example of that not all the lung cancers are the same. Even adenocarcinoma of the lung has different response depending what it is. So if you have a SNR and papillary versus a solid lung cancer, the survival is different and the response post-operatively is different. Two details to go into the detail of this slide, but just an example that every lung cancer is not same. Even every subtype of lung cancer is not same. There's subtypes of lung cancer, and the treatment is targeted and customized as per the outcome is. So if you're stage 3 lung cancer, if it's resectable, you get chemo radiation first and then surgically resect. If it's unresectable, you get chemo radiation and immunotherapy for these. For stage 4, most of the time now patients are getting immunotherapy as a first line treatment. So I want to conclude actually here my talk that lung cancer screening has shown a significant survival improvement, 20% reduction in mortality in a US trial and 25% reduction in mortality in the European trial. Two-thirds of all lung cancer found in lung cancer screening programs are usually stage 1 lung cancer and resectable. And for early stage lung cancer, robotic segmentectomy, which is a robotic segmentectomy, which is a lung preserving surgery, is a preferred approach because it can be done even in patients with COPD who are on oxygen for 2-3 liters. Once the lung cancer is removed and resected, depending on the subtype, depending on the lymph node involvement, the necessity of chemotherapy or chemoradiation therapy is determined depending on the final pathology. Thank you very much. I'll conclude my talk here. Thank you.